think about another example, right? If we have an image of the brain and there is an area of hemorrhage, so we are going to have signal loss in this location in the brain in proportion to the magnetic susceptibility of those blood products. Now, the first thing I want to be clear about is that the magnetic susceptibility of blood comes from what component of the blood?
Iron.
Right, it comes from the iron in the heme part of the hemoglobin molecule. Now, iron is not a source of the MR signal that we measure. So let's just be clear up front that what we're going to be looking at is the impact of the presence of this iron on the magnetic field, which affects the signal that we detect from water protons. When you image blood with MR, you are not imaging the blood per se. You're imaging its secondary effect on tissue. That's very different, for example, from CT, where the attenuation of the X-ray beam is a direct function of the globin protein in the hemoglobin molecule. Here we're looking at a secondary effect. So that's number one, is that we're not imaging the blood, we're imaging the tissue and the impact of the presence of that blood on the tissue. Second is that the iron in hemoglobin will only have an effect on this tissue to the extent to which we have paramagnetism. Okay. So, for example, if we look at what happens when someone has an intracerebral hemorrhage, that initially we have some ratio, right, of oxygenated, right, to deoxygenated hemoglobin. And it turns out that, right, over time, as many of you know, there is a progressive change in the state of hemoglobin as the clot in this hematoma is going to evolve and be degraded and resorbed. And we are going to get to a point where we have predominantly deoxygenated hemoglobin. Then, as that hemoglobin molecule becomes oxidized, we'll have methemoglobin and eventually formation of hemosiderin, which gets scavenged up by inflammatory cells, right, microglia and macrophages, and stays around in the tissue in that form forever. So depending on the state in which the hemoglobin finds itself, so to speak, that's going to determine the effect over here on the image. So, for example, iron is paramagnetic. There's always, right, iron in all of these cases. However, we're not always going to see a magnetic susceptibility effect. For example, if we look at the case of oxygenated hemoglobin, right, which is something you'll probably never see because it takes so much time for the patient to ultimately get into the scanner. But oxygenated hemoglobin on our magnetic susceptibility scale is actually in the negative range. It's a diamagnetic molecule. And the reason for that is that the magnetic susceptibility effects of iron are shielded, right, or are opposed actually by the presence of the oxygen molecules. So when you look at a region of brain where there has been a hemorrhage, if it contains oxygenated hemoglobin, you won't expect to see any of these characteristic effects. Specifically, you won't expect to see that kind of signal loss. The change from oxygenated to deoxygenated hemoglobin results in a change in the conformation of the molecule, right, such that we now have a dramatic magnetic susceptibility effect and very large amount of signal loss. Now, by the way, if you wanted to maximize your ability to detect this effect, what type of image would you use? Right. You would want to image T2 star. Right. The spin echo is going to compensate for these magnetic susceptibility effects. So if you want to make your image sensitive to the presence of deoxygenated hemoglobin, for example, you want to use an image that is maximally sensitive to T2 star differences, such as a gradient echo image. A spin echo, or especially a fast spin echo image, is going to be much less sensitive to these effects. And the remaining forms of hemoglobin, methemoglobin and hemosiderin, have progressively increasing degrees of magnetic susceptibility and will cause an increasingly profound effect on the signal within our T2 star weighted image. Okay. Now, there's another phenomenon going on here which has something to do with the nature of hemoglobin, but is totally different than this bulk magnetic susceptibility effect. And that is the fact that these paramagnetic substances, as we talked about when we talked about contrast agents, that with gadolinium, for example, we said that the gadolinium electrons can interact with our water protons to dramatically accelerate spin lattice relaxation, right? To shorten the T1 of our whatever it is that we're measuring. But the way that we see contrast enhancement in a T1 weighted image is due to this dramatic shortening of T1. That's due to the unpaired electron of this paramagnetic gadolinium ion interacting directly with our water proton. That's something that is also going to be going on in the situation of iron, right? Paramagnetic iron in our hemoglobin. So we would expect that all of these various states of hemoglobin, deoxygenated, methemoglobin, and hemosiderin, which are all paramagnetic, have a similar interaction with our water protons and accelerate T1 relaxation. But the reality is that that's not the case. Right? That deoxygenated hemoglobin has no impact on the T1 of the tissue. And if you look at a T1 weighted image, you will not see T1 shortening. You won't see high signal even in the presence of large amounts of deoxygenated hemoglobin. Why? In order for this effect to take place, we said this is called a proton-electron dipole interaction. The prerequisite is that the proximity of the proton and the electron has to be less than 3 angstroms. The conformation of this deoxygenated hemoglobin molecule is such that the iron atoms are shielded inside the molecule and the protons can't get close enough for that spin lattice energy exchange to occur. And this is a all or nothing effect. If you don't have that proximity, it doesn't happen at all. The same thing is true in the case of hemosiderin for a slightly different reason. Hemosiderin is also a molecule containing many, many iron atoms, and as a result it is extremely paramagnetic and causes the most dramatic signal loss when we look at our T2 star weighted images. But again, because of the way the iron is organized in the core of this hemosiderin molecule, there's no access for water protons to get close enough, and as a result we don't see that effect. So it turns out that it's only methemoglobin which, due to the conformation of the molecule, this change that occurs with the oxidation of deoxygenated to methemoglobin, that you have a hemoglobin molecule where the iron is exposed and able to have enough proximity to those iron electrons to undergo this proton-electron dipole interaction.
Does it matter whether that hemoglobin is intracellular or extracellular?
Not for that effect. We're going to get to that in a second. So if we map out here, just to keep this straight, what is going on, we've said that if we compare, right, deoxygenated hemoglobin, methemoglobin, and hemosiderin. So we've said, first of all, right, which of these are paramagnetic? Well, they are increasingly paramagnetic. Okay. Right, because they are increasingly paramagnetic, we would expect that they would all lead to, right, on a T2 star weighted image, what effect on our signal? There would be loss of signal. And then if we ask a second question about this 3 angstrom rule, the only one that meets that criteria is methemoglobin. So if we would look at a T1 sensitive image, we would expect to see no effect from hemosiderin or deoxygenated hemoglobin on our T1 weighted image, whereas we would see what effect on signal amplitude if we have methemoglobin? An increase in signal. Okay? And this is the general schematic of how these paramagnetic substances influence our signal. Now, there is one caveat, which is that deoxygenated hemoglobin is oxidized to methemoglobin while those red blood cells are still intact. So this is all occurring inside the cell. And as a result, there is a very high concentration, local concentration, of methemoglobin inside the red cells, and there is none outside the red cells. So if you think about what is going on in the clot, is we have localized foci containing this paramagnetic substance, intervening serum or water or whatever it is, which is essentially diamagnetic. So there are dramatic gradients of magnetic susceptibility. But at some point in time, while we're still dealing with methemoglobin, right, there is going to be this lysis of our red blood cells. And the methemoglobin will now diffuse throughout the area of the clot. Right? So we'll now have what people sometimes call extracellular methemoglobin. What impact does that have on the paramagnetic nature of methemoglobin? None. It's still methemoglobin, right? And it is still paramagnetic. But it does have an impact on the signal that we see in our image, because now we don't have those gradients of magnetic susceptibility. This paramagnetic stuff is now at an even concentration throughout the clot. And we lose, right, that signal loss due to T2 star mechanisms. So this really just drives home the point that I tried to make earlier, that it's not the absolute magnetic susceptibility. It's the gradient of magnetic susceptibility.
And why is there's only a gradient when it's intracellular?
Because when it's intracellular, it's located in these pockets in the cells, but not in all of the intervening serum. So if you move across the whole volume of clot or tissue, whatever you want to call it, you move from areas with high concentrations of methemoglobin to 0 to high to 0 to high to 0. So, and this is all going on within a voxel. I mean, these red cells are tiny, right? So within a single voxel, we have components that have high magnetic susceptibilities and components that are diamagnetics. There's dramatic signal loss. But if all of a sudden within that voxel there's a uniform concentration of methemoglobin, there's no more gradient of magnetic susceptibility.
And when the macrophages will take it up, then you
Exactly. So hemosiderin, okay, first of all, hemosiderin is much more paramagnetic to start with, but the hemosiderin is localized within these inflammatory cells. Absolutely right. Now, how does the fact that our red cells have let go of their membranes and had this methemoglobin diffuse through the tissue, how does that impact this 3 angstrom rule? Well, it doesn't really have any effect at all. Water protons, right, can still get just as close to those iron atoms as they could before. Right? So we still make this qualification, and we still have high signal on our T1 weighted image. Right? So by understanding at a molecular level what's going on with the hemoglobin and how these 2 characteristics of this paramagnetic stuff interact with our signal, you could reconstruct this yourself. It's much better than itty bitty baby, isn't it?
What's that?
Isn't that what it's called? Isn't that the mnemonic? I don't even know what it is. I just have heard about it. Okay, any questions about this? Let's look at an example. So, first thing, before we look at this actual blood issue, is I want to make the point that, as the radiology people are probably all well aware, these magnetic susceptibility effects are not just, nuisances that we have to put up with, but they actually have diagnostic utility. So in this example, we have 2 of our sort of standard types of imaging sequences that we always use when we image the brain, FLAIR and turbo or fast spin echo T2 weighted images. And if we look at the brainstem in this patient, it doesn't look normal. It has this sort of patchy signal abnormality. But the thing that would be hard to detect, if you look closely, you can see it on the fast spin echo image. But by using a gradient echo image, we can really bring out this area of low signal, which is a small focus of hemorrhage in the brainstem. So using images that are sensitive to these T2 star effects allows us to generate diagnostic information. And it's important to keep in mind that if you don't have this image, it can be very hard to detect some of these effects, whether they're small areas of calcification, small areas of hemorrhage, small vascular malformations that have blood products in them, whatever they happen to be. So here's another example of a patient with something going on in their brain. There's an area of volume loss, and it's the gradient echo image on your far left which is going to most dramatically clarify for us that this dark stuff around the cavity in the brain is blood products. This is an old hemorrhage from an AVM. This phenomenon where we see a dramatic increase in the area of signal loss going from a T2 weighted image to a T2 star weighted image is something that we call blooming. And here's another example where you don't see anything on the T1 weighted image. The T2 star weighted image shows you this large area of magnetic susceptibility effect. And not only that lesion, but when you look at the rest of the brain in this patient, and these ultimately were multiple cavernous malformations, you can see many additional areas of abnormality that these weren't apparent at all on the T2 weighted images. So if you want to be sensitive to these effects, you have to use an imaging approach, T2 star, that is going to detect them. Now, to just look at what we were talking about with hemorrhage, this is actually an example that comes out of the book. Here are our 3 or 4 rather stages of hemorrhage, right? Deoxyhemoglobin, methemoglobin, which we can subdivide into intra and extracellular, and hemosiderin. So notice T1 weighted images on the top, and these are T2 weighted images on the bottom. Even though we would be maximally sensitive to the presence of magnetic susceptibility effects with T2 star weighted images, we will still see those effects on a spin echo image. One of the reasons for that is, right, because you would expect these are magnetic susceptibility effects. Why aren't they totally compensated by the spin echo, by the 180-degree RF pulse? The answer to that has to do with diffusion. Okay? And what I mean by that is that if we think about, let's say, we have some volume of our image where there is a gradient of magnetic field strength, which is due to the effects of hemoglobin. This isn't an applied gradient magnetic field. What I mean here is that there's variability in the magnetic field strength. We could never predict exactly what it is, but there is some point-to-point variability based on the presence of that blood. Well, what we expect then is that if we have our magnetization generate signal, that there will be some dephasing that occurs based on the fact that some of these spins are in areas with higher field strength and some in areas with lower field strength. And we expect that the 180-degree RF pulse should generate a spin echo and refocus that magnetization. That's based on an assumption. And that assumption is that during that entire period of time, from when we generate the signal through the initial dephasing, 180-degree RF pulse, and the rephasing, that these experience the same difference in magnetic field strength. If there is diffusion of these spins through the tissue, such that they change their location during that period of time, then although they might have dephased this much initially, if after the 180-degree pulse they're in a different location, they will not rephase completely because they don't have the same difference in precessional frequency. So even a spin echo image should show us this effect. So deoxygenated hemoglobin, notice that it has no effect on the T1 weighted image because the molecule shields those water protons from getting close enough to the iron electrons to undergo that proton-electron dipole interaction. As soon as we have methemoglobin, right, that's no longer the case. In this example, the periphery is methemoglobin, the center is still deoxygenated hemoglobin. That's what we all expect, is that the evolution of the hematoma should occur most rapidly or earliest at the periphery and then move in. So that's the contrast between a simple conformational change in the molecule allowing that proton-electron dipole effect to occur. And then it persists in the case of extracellular methemoglobin, and it's gone in the case of hemosiderin. Okay. This high signal in the case of hemosiderin is actually due to the fact that it is so strongly paramagnetic that it causes some distortion and movement of signal to places in the image where it doesn't belong. It's not due to a proton-electron dipole interaction. And on the other hand, we have this prominent magnetic susceptibility effect on our T2 weighted image, whether it's deoxygenated hemoglobin, methemoglobin, or hemosiderin. It's all the same effect. The only difference is that in the case of extracellular methemoglobin, because there has been lysis of those red blood cells, throughout the hematoma, there is no longer any gradient of magnetic susceptibility, so we don't see that signal loss. Okay. Any questions about that? Yes?
Can we just talk about the oxygenated blood, or the, I guess, hyperacute?
Right. So the so-called hyperacute hemorrhage, which I deliberately ignored.
Sorry.
The reason that I deliberately ignore it is, first of all, and this answer is a cop-out, you'll never see it anyway, so what's the difference? Okay? But that being said, that's simply because once the blood leaves the intravascular space, enters tissue, those red cells are still metabolizing oxygen, still burning oxygen, and you very rapidly have a transition to deoxygenated hemoglobin. So within the time frame that someone is going to have a hemorrhage and end up in the scanner, it's gone. But that's beside the point.
Okay, but it comes up at some points, right? I mean, or rebleeding, or we never see it? I mean, we just talk about it theoretically?
I don't know. I've been doing this for more than 10 years. I've never seen it in real life. I have one example that someone gave me. I've never seen it.
What was the example? Oh, it was just an accident.
It was a situation where they imaged someone, supposedly imaged someone very rapidly. But this is all kind of not really the point. Oxygenated hemoglobin, right? So the oxyhemoglobin molecule, because of the oxygen atoms, they shield the paramagnetic nature of the iron in the core of the hemoglobin molecule. So there is no magnetic susceptibility gradient. And if you look at a T2 star image, there is 0 signal loss in the setting of oxygenated hemoglobin. Okay? There is similarly no proton-electron dipole interaction, because those iron atoms, those iron electrons, are not able to get close enough to a water proton to accelerate its T1 relaxation time. So we would think, based on this, that hemoglobin should be having no impact on the signal of our tissue. Now, the tissue we're talking about here is a clot. It's a lump of blood, which includes both red blood cells, white blood cells, a few of them, and a lot of serum. The red blood cells, of course, contain hemoglobin, but they also contain other stuff as well. Whatever signal you see in the setting of oxygenated hemoglobin is a function of all the other stuff in the hematoma. And so what you're seeing, if you see slight hyperintensity on a T2 weighted image, or some rim of hyperintensity on a T1 weighted image that have been supposedly reported, that's all a function of those serum proteins and other water content of the hematoma. It has nothing to do with any of these magnetic susceptibility effects.